Just waiting for a few more people to get started. I'm really excited today. We have Dr. Amy Mulan with us. And so it's always special when we have our founder, one of our founders of the Bridge, California Bridge. So we're truly going to get started in just another minute or so because we want to make sure we have enough time today. So just type in the chat, let me know who's here, where you're from. Okay, and just for the best experience today, make sure you have your computer is plugged into a power outlet, close unnecessary windows, it slows your computer down. Use the chat for any questions. Welcome, Alicia. Connect to audio for breakout groups. Remember, this is a regional meeting, so we will have our breakout sessions more towards the end of the presentation. So make sure your audio and your video is ready for your breakouts. Welcome, Ashley, Sue, Dale. Wow, we have everybody here. Cindy Watson, I'm so happy that you guys could join us because we have some great information today. Definitely, we are going to get started here. I think everybody's still coming in. The numbers are still climbing, so I'll wait until we're still letting everyone in. So thanks, Claire from Tahoe Forest. That's wonderful. We're so excited to see you here today. We have all of our Sun mentors, so we'll have that for the breakout. And I guess, has my numbers stopped growing? I think so. I think we're at a good point I think, yeah, the numbers stop. Okay, so we're going to get started, you guys. Welcome to our Sun Regional Meeting. This is Newest Trends in MAT and SBIRT. So we're really excited. We have Dr. Mulan, as I said before, and Ariana Campbell-Sampson is our PAC. She'll join us. We'll let you know and keep you updated. She's in the area of the fires. So Dr. Mulan has graciously agreed to kind of help out. So we'll keep you in the loop. So as you know, we're in California Bridge and all of our materials are made under a Creative Commons. So we will be sharing this and it will be recorded. So just today, what we're going to talk about is SBIRT, screening, brief intervention, referral to treatment. We're going to talk about the newest trends in medication for addiction treatment. We're going to have our breakout sessions and with our Sun mentors. These are our objectives, and I just want to say I'm honored to have Dr. Amy Mulan. She's a professor at UC Davis and the behavioral health director for the emergency department at UC Davis. She has a dual appointment in the Department of Emergency Medicine and Psychiatry. Amy has a master's of applied science and completed a fellowship in quality, safety, comparative effectiveness research through the Agency for Healthcare Research and Quality, with a focus on acute care for patients with behavioral health disorders. She completed and established a health policy fellowship at UC Davis. She is the past president of the California chapter of American College of Emergency Physicians. She completed her residency at LA County and USC Medical Center, and she is one of the founding members here at California Bridge. Dr. Mulan, we are honored to have you here today.
Thank you so much, Sherry. I'm excited to be here, and thank you for that introduction. You make me sound like a big nerd, but I appreciate being here. And as nerdy as I sound, I really just wanted to take a moment to thank everybody on this call, because my favorite thing is to get to talk to our sons, because you guys are the ones who are doing the work. You guys are the ones who are out there saving lives and really making a huge difference in our communities. So this is just a big moment, a shout out for you, and I'm honored to be here. So thank you all. Okay, so just wanted to take a moment to say, like, this is our model, California Bridge, and what we do is treatment now. And you are out there revolutionizing addiction treatment. Because what we used to do is this model of treatment later. We'll talk to you a lot, we'll refer you, we'll make things really complicated, and it was treatment later. And that did not work. And so what you are doing is treatment now, and you are getting people started, you are reaching out to them, and you are making all of the difference in the world. So this is a picture of UC Davis in our ambulance bay of bringing patients into the ED who need treatment now. And that is the same for all of our people out there who are struggling with addiction. They need treatment now. And so our message is really more meds, less death. And you guys are making that happen. So I just want to say huge thank you, and I'm honored to be here. Okay, let's move in. Next slide. Now we're going to talk about kind of the boring nitty-gritty stuff. So I want you guys to interrupt, pop in the chat, ask questions. I don't like, just me talking. I'm an emergency physician. I like to be interrupted. Otherwise, I don't know what's, it's really weird for me to not be interrupted. So pop in the chat, ask any question. No question is not a good question. They're all great. And really, if you're just asking a question to make me feel better, I appreciate you. So SBIRT, this is a piece of what you do every day. It's the screening, brief intervention, and referral to treatment. You do so much more than this, and there's so much more work that goes into doing what you do that I don't want to underestimate that. But this is in terms of, what is billed and what is a procedure and what is seen in the healthcare system. They reduce it down to these 3 activities: screening, brief intervention, and referral to treatment. I know what you do is a lot more complicated and involved than this, but this is how they kind of break it down. Go on to the next slide. How many of you are familiar with SBIRT? Just pop in the chat, have done this before, have seen these words. Let me know. Ooh, good questions. Jill says, can we bill for SBIRT? And we're going to get there, because that's really the key question. Why we're doing this in the ED is we recognize, and you know this, and I know this, but our patients are super high risk for SUD. This is where the patients are. That when we do screening, about 28% of our adult ED patients will screen positive. This is all comers. But about only 17% are discharged with the substance use diagnosis. So clearly we're missing some folks, or there's some reluctance to diagnose them. Move on to the next slide. Okay, so this is the SBIRT. So this is the process of the screening, brief intervention, and referral to treatment that a lot of you are familiar with, which I'm excited about. When you look at the SBIRT, which is this brief intervention, referral to treatment, and you compare doing the SBIRT in the emergency department versus doing it in primary care versus doing it in other settings, we have found that it is actually more effective from the emergency departments, that it is more cost effective from the emergency departments because of 2 things. One, what we talked about before, there's higher incidence, as we know, of substance use disorders in our ED population. But there's another key, which I think is really interesting and speaks to the work that you do and how you're able to access people. When they compared screening, brief intervention in primary care versus the ED, the same person in one of these studies who screened negative in primary care screened positive in the emergency department. And I'm curious if anyone here can think of why that would be. Pop it into the chat. Same person, screen for substance use, treatment in primary care, negative, screen positive in the emergency department. So I'm seeing stigma. Oh, the UTOX, the ever wonderful UTOX. I think what the authors of that study was really what Rebecca just put in there. It's a crisis moment, that there's a little bit of the anonymity of the emergency department, different level of where that person is. Usually you can link whatever brought them into the ED, you can link that to the use disorder. Patients are more vulnerable. We see them in a place when they have an acute need. It's that teachable moment. So we have a really important role in this SBIRT and the screening phase in our EDs. Then when we move on, and you guys are putting some fantastic stuff, the patient's more vulnerable, you guys can take time to really listen to them. And I think it is really a wonderful moment. So then we move on from screening, and we know we have a huge opportunity, and we know we have this great moment when we can reach people. And we look at the impact that we have of that brief intervention, that motivational interviewing that we're doing in our emergency departments. And they did a study of this, and they found that motivational interviewing piece, adding that in, really improved engagement in care. So in a VA study, when they did motivational interviewing in the emergency department, combined that with the screening, 80% were able to be linked in care versus 12%. So overall, we have seen our efforts in the emergency department around SBIRT to be highly effective, and actually often more effective from the emergency department than from primary care. Let's go on to the next slide. Any questions about that? Okay, we're going to keep moving. So how do we do the SBIRT? A lot of you are really familiar with this, but there's tools. So as we kind of dig in, there's sort of the mechanics of the SBIRT, which is what you do, and then there's, as we put into like, what do they consider the SBIRT in terms of documentation and just the mechanics of doing it. And really the audit and the DAS-10, these are the workhorses of the SBIRT. So both of these tools are recognized by Medicare as screening tools for SBIRT. The audit is specific for alcohol and the DAS is for drugs. We frequently use the DAS-10 because it is less questions. So these are the two that we tend to use most frequently and they're most frequently recognized. How many of you are using the audit and the DAS formally in your practice? I'm just curious, pop it into the chat. They're very analogous. So they're similar questions, but it's a structured interview. And I see a lot of you are using both. So that is just fantastic. Take a look at them if you're not. It's probably stuff that you are all already asking. It's just a more structured way of doing your assessment interview. Okay, we'll go on to the next slide. Then we move on to the brief intervention. This is less structured. So in the formal SBIRT procedure that is recognized by Medicare, there is no formal documentation of what the brief intervention is. So this is where we can kind of put in our own art form. Things that have been recognized are de-escalation as a brief intervention. So a lot of times we will see patients who often have are in different spaces in their kind of trajectory of intoxication, withdrawal. They can have some co-occurring mental illness and often need some de-escalation, and that can be considered a brief intervention. Patient education. I think a lot of what happens in our emergency department is just education, and then offering a change menu. So these are presenting the patient different options for change. This is part of how we meet them where they are. Motivational interviewing, which is a fantastic technique. And really, for me, all of these come down to the principles of harm reduction. I would love to hear from you as experts. You are all experts in the brief intervention. What techniques you use and which of these kind of really speak to you that you use in your practice. And other things we can learn from each other is like which techniques are working, how can we learn more? Because this brief intervention is less structured. So we have more options here around how we reach patients and what we feel works for them. So go ahead and put in the chat what you guys are doing, what techniques you use regularly, and what you did more. I think really the key is kind of this concept of harm reduction, which is where we meet people where they are. I love this thought of you meet people where you are, but we don't leave them there. So everything that we do is trying to keep them on this path of recovery. I love this active listening and respect. That is wonderful. Thank you, Abby. Motivational interviewing from Troy. Yes, active listening. Anna's doing cognitive behavioral therapy. That is amazing because that does take a lot of work. Reflective listening, asking permission, promoting change talk. Thank you. These are all wonderful. You guys are such experts in the brief intervention, and I think this is why we are so successful. Angela says, it starts with the way you introduce yourself. And I 100% agree. This is amazing. The first impression is really huge. You guys are really the experts here. So we have talked about screening, which is very structured, where you're talking a little bit about that brief intervention, which I think is the key to change, but it's less structured. This is where you guys have been the experts, a lot of motivational interviewing happening out there. And now we're going to talk about the other piece, which is referral to treatment. The people in the picture are not wearing masks. You are absolutely right. It is an old picture. Tanya noticed this. It is an old picture. This is another old picture too. Those are some of my crisis social workers. And why I like that picture, if you go back, is what they have hanging behind them is food and snacks, because one of the things that people always need in the emergency department is food and snacks. And so we have found that providing just food is often helpful. Okay, go on to the next slide. This is another picture of folks without masks. This is a picture of the Transitions Clinic in Sacramento. This was the first place that we were able to refer people from my emergency department. It was a pretty informal clinic that was kind of cash versus grant-based. You could kind of walk in. It was pretty low barrier. But really what this is the key is that referral to treatments. And the connection to care is really one of the keys to success. This is a piece of the SBIRT, but we all know here that is so much more than that. It is not just handing someone the piece of paper. It is not just saying, here's where you show up. It's community outreach, transportation, working through pharmacy problems, housing, childcare, insurance. So yes, this is also the key to success, but is less formally documented in terms of what the SBIRT is. So just to review, SBIRT, which is the formal process recognized by Medicare, is the screening, brief intervention, and referral to treatment. For screening, they have very structured interviews. The brief intervention is where we really show the art of medicine and what we're doing. And then referral to treatment, I think, is what we do so much more intensely than any other group. Okay, let's go on to the next slide and let's talk into some more nerdy stuff. So in terms of documentation, I love you guys out there talking about giving people food and warm blankets and warm clothes. Warmth is comfort, and I 100% agree. And this just really reminds me, what you're putting in the chat is how much more important and how much more robust and human these interactions need to be versus on my slides, I have for you what is required documentation for an SBIRT, and none of the actual deep human connection that you are providing is actually in this documentation. And so it really just highlights for me the disconnect between, medicine and what is important. Because this robust discussion that's happening in the chat is just so wonderful and beautiful and shows why you are effective versus other programs which just can document and be successful. So required documentation has nothing to do with soup and warmth and turkey sandwiches, but everything to do with past history, document either an audit or a DAST, options for treatments, connections to ongoing care, and contact information. And so that documentation is what constitutes an expert from Medicare. And so it's really that structured interview. And as I mentioned, all of the really good work that you do in terms of the brief intervention is unstructured and not required documentation wise. Okay, next piece. So expert billing, I'm going to get to this question around expert billing that we have. Can you bill for an expert from the emergency department? Kind of. This is our picture here. So you can bill for an expert, but there is no required covered benefit from the emergency department. So I have heard that some sites are able to bill for an expert successfully, but it is not required. It is a required covered benefit in the state of California from primary care, but not from the emergency department. And so this is the key piece that we've been talking about, because what we have learned and what studies have shown is that it is actually more effective from the emergency department, more cost effective from the emergency department. And what you are doing is so much more robust than what is required and what is frequently done in other settings. So the answer to this is not yet. You can bill. I do know some sites where the insurance companies are reimbursing, and if it is in their contract, they will bill for the expert, but it is not required. That's something that I am working on because I know that your work is so key here. Happy to answer questions on this piece. Okay, we'll go ahead and move on to the next slide. So this is billing. This is the key for billing. So expert, this is the fee schedule for expert billing. You can only bill for a positive screen. And as you can see, like this is actually decently reimbursed. These are the codes that are reimbursed. They are required to be reimbursed through primary care, but not from the ED. Can physicians bill in the ED if we do it? Yes, yes and no. So if an expert is documented and co-signed by a physician, by someone who is qualified to do the expert, then it would be billable if the insurance company had agreed to cover it. So if your group had an agreement with an insurance company, with a managed Medi-Cal plan, then they could bill it if you had it documented this way. It is not a required covered benefit. So currently, most plans do not reimburse for an expert from the emergency department. We are working to change that because we know it is so important, because we know it is so effective, because we know it saves lives and saves money for the healthcare system. That's what we're working to change because it is not currently required. So these are some great questions. And yes, we will make the slide deck available. Next slide. This is, I know some of you have also asked about assessments. ASAM assessments, these are some of what some of you have done as part of drug treatment clinics. These are the long intake interviews that are required for the drug Medi-Cal program. So ASAM assessments, unless you are part of a drug Medi-Cal program, are not currently billable from the emergency department. These are kind of those long assessments that are often required by the county in order to enter into the system. Yes, so Anne just mentioned an ASAM is a long assessment, and Anne mentioned that it can often take 3 hours. These are long. So this is a different assessment, and this is for the county system. Unless you are within that system, it's not currently billable, nor is it required. Hopefully that answers some of those questions that we've been getting around the ASAM assessment. Christine asks, is this the assessment for outpatient clinics? Yes, this is what they're often doing in order to the intake assessment. This is why starting treatment in the ED is so helpful, is that we're able to begin treatment before someone has to go through this long assessment. Okay. Other questions here? Next slide. Okay, and I hear that Ariana is here.
Yes, she typed me in the chat. Ariana, are you here?
Yeah, I'm here.
Awesome.
Hello, everybody.
Ariana, because I wasn't sure if you were here, I added a slide, one of my fentanyl slides. So if you see it, either just jump right on through it, where it might be a little Easter egg for you and everybody else on the talk. Happy to answer any questions for anyone there, or anyone who has any other questions. You can email me and I will get to you. I have one question before I pass it on officially around SBIRT billing. So SBIRT can be, SBIRT from a clinic would be billed. So if we were all clinics and SBIRT was required to be paid, we would bill, and it would be a procedure. So it would be like a professional fee. So if the SBIRT was billable from the emergency department, that would be reimbursed to whoever was doing it. Does that answer that question for Christine? And I can happy to follow up on email with anyone who has more questions on this.
I had a question in chat that I think do you know whether in Cerner there is a template or anything for the
audit or the DAST?
Yes, thank you.
I don't know if there is for Cerner. We use Epic, so I know that we have one for Epic, and I'm just curious, is there anyone else out there using Cerner who might have it?
Yeah, I got a couple people looking into it. I just was wondering whether you knew. Okay. Thank you.
Yeah, no, great question. Okay, I'm gonna pass it on. Thank you guys so much for having me. I just love being able to be here with you. You are all doing such great work, and just appreciate everything that you do, and happy to help in any way. I'm gonna put my email in the chat so anyone can go ahead and contact me.
Thank you.
Thank you.
Oh, thank you. We really appreciate this, and for clarifying the SBIRT and the billing. This was amazing, and I wanted to reassure everybody you will get the slide deck, and this is being recorded, and both the slide deck and the recording will be sent in a follow-up email, because I know this was really important to a lot of our sons. So thank you very much. We now have Ariana Sampson. I'm very excited because she's in the fire pathway. She could probably explain it better than I can. So it was up in the air if she could make it, but she felt compelled because she loves coming to our Sun events. For those who don't know Ariana is an emergency department physician's assistant with 20 years of clinical experience. She is the advanced practice provider lead for U.S. Acute Care Solutions at Marshall Medical Center in Placerville, California. She has been involved in developing programs to initiate medication for addiction treatment in the emergency setting since 2017. She is passionate about creating and innovating the emergency department and hospital as an open door for patients with substance use disorders to receive life-saving treatment. Ariana received her physician assistant degree from Western University of Health Sciences. She's also one of the founding members here with California Bridge. So I am honored today, and I'm so glad you could join us, Ariana. Thank you. I know you have a lot going on.
I do. And I just wanted to get on, actually, I'm in a private place, so I can take this off. But I am just here to, I just wanted to answer any questions kind of on updates and current trends. I can tell you right now, I'm at a hospital about 8 to 10 miles away from the big fire. So anyway, and I'm on shift, and I wanted to take just a few minutes just to see if there's anything I can answer for anybody that is, on this call in terms of current trends. Right now, we're seeing a surge in COVID in my community. So we unfortunately are experiencing a surge in COVID. We're experiencing a surge in opioid overdose. Opioid overdose is associated with fentanyl, and so we are experiencing a wildfire with a significant amount of our population who's displaced right now. So, so there's a lot going on in my community right now. But I wanted to go through. Oh, thank you, Kelly. I did want to go through, and really just wanted to be here to answer any questions. I'm very passionate about what you do as substance use navigators, and I know that when you're getting into this role, there's quite a bit of, I can tell you I have a project manager who started, and he just got inundated with questions about how to transfer patients over to buprenorphine and fentanyl and all these things. And so though we know you're not responsible for all of these medications, you are certainly the ones who are kind of in between and responsible to do a push of resources. So so I want to see if there's any burning questions before, and I'm happy. Oh, okay. My doctors will only here. Let me just take this off. All right. My doctors will only order 2 to 4 milligrams of buprenorphine. How do I get them to have a higher dose? So Sherry, I'm hoping that you could actually put this maybe in the chat. There's a recent article that Andrew Herring and actually Josh Luftig and Gail D'Onofrio put together that are actually that will substantiate the higher dose. I can tell you the way I describe buprenorphine dosing is the FDA approved dose. The dose that you'll hear about is 2 to 4 milligrams. And so for some historical perspective, you'll see that people want to give that dose because that's what is in some of the literature. In the emergency department setting, what I can tell you is I call 4 milligrams the confusing dose. And the reason being is the way that buprenorphine works is it occupies a part of that mu receptor, the opioid receptor. Now, it's really kind of sticky to it. So if you give buprenorphine and somebody has just used heroin or fentanyl, it'll bump all of that full agonist or that full agonist drug off of that receptor. And yet it's not strong enough. Sorry, I have a vocera. It's not strong enough. Like it's a partial agonist, so it'll put somebody in withdrawal just because of the it only has a partial activation of that receptor. So hopefully that's not too nerdy for you. But the reason I mention that is because 4 milligrams I call the confusing dose of buprenorphine, because it's enough to bump off like heroin or fentanyl, but it's sometimes not, and frequently not enough to actually fully treat the withdrawal. So when somebody doesn't get better, you kind of don't know why. So you don't know if you just didn't dose enough, or if you, what's called precipitated withdrawal, if you actually caused withdrawal. And so almost always I end up giving more. And I actually told this to a student once, and then I gave 4 milligrams anyway, because it was somebody who had some comorbidities, who was like older and had some medical problems. And I was a little concerned. And my student reminded me of that. So I thought I would tell you. So if I am concerned that somebody is at risk of a precipitated withdrawal, or if I am concerned that somebody is like, I need to be a little more gentle with them, I go much, much lower. I actually go like 0.5 to 1 milligrams. I don't do like 2 to 4. And then if somebody's really clearly in withdrawal and has not used in the last 8 hours, then I will give 8 milligrams, because it's a better dose to really clarify that. So let me keep up with some of these questions. You guys have such great questions. I'm so happy that you're so engaged. Okay, so, thank you, Christian, I think put on the high dose article. So one of the concerns is that with the high dose that you would end up, there's this concern of what if it's too much, right? Well, the high dose article is really good for establishing that it's super safe. In fact, when we gave high doses, we see less precipitated withdrawal, probably because of that confusion at that 2 to 4 milligram dose. But you can use that article. And there's also another one that was published in Annals of Emergency Medicine that gives, that's more emergency department focused. And it does give that 8 milligram first dose as an option. So it may be that your doctors want like something in print. And those are, I don't know if you have that Annals article, Christian, that Andrew put together, and I think it was 2019, but that would be another one that you could utilize just to hand to your doctors. I know it can get tricky as a substance use navigator. So anyway, having some of those things on your side can really help. All right, and then the picture was fentanyl dressed up as oxycodone, it looks like. So, you know, what I say is every pill that we see on the street, you can consider it being fentanyl. And yes, Rebecca Harris says, has anyone noticed a rise in fentanyl in cannabis? I know they've been doing some testing locally with my some of the stuff on the street in my community, and like everything has fentanyl in it right now. I even had a patient recently who we thought had a kidney infection, and it turns out she had quit methamphetamine 3 or 4 days before. And when I really teased it down and went through opioid withdrawal, it really appeared that she was in opioid withdrawal. Our drug tests don't pick up fentanyl, so that wasn't going to help me in the ED. But I gave her a little bit of buprenorphine. I actually did give her a smaller dose, and she got significantly better. I think I ended up giving her like 8 milligrams, and she did great. The other reason we feel really good about buprenorphine is and this is something that you should just know, is that it has a ceiling effect on respiratory depression. So it's really safe at these high doses, because we're not going, people don't stop breathing. The lowest, I think, when you look at the charts, everybody gets a little bit of, the way people die from opioid overdoses, they stop breathing. So just to keep it really simple, when we give buprenorphine, it really has this protective effect, and it doesn't doesn't stop them from breathing. So yeah, so some of the comments are, yeah, you're seeing fentanyl and cannabis a lot more. Fentanyl fentanyl can be in anything. And when somebody said, how does fentanyl withdrawal factor in? This is a really good question. A lot of places are using a higher COWS score for fentanyl, like a COWS score of 12 rather than 8. What I can tell you is with fentanyl in particular, I have been finding that it takes a lot longer for folks to be in full withdrawal. So I do more home starts, actually. Sorry. So I do more home starts, actually. And when I do home starts, then the patient can choose the dose themselves, but I usually do a very slow home start. Does anybody have Vocera in their place? Okay. All right. So anyway, and then I have one that says one of my patients left AMA from inpatient because they'd only give him 2 milligrams, in which he continued withdrawing. Prior to overdose and intubation was involved. Yeah. So one thing I'll say about leaving against medical advice when somebody is inpatient is, and I'm having this conversation in my hospital right now, it's really important that that you either really treat pain very aggressively or treat the withdrawal and therefore pain aggressively, but some folks end up in between. And for that particular question, in between is the worst place to be. So again, I would point your physicians to our resources, because this isn't your job to like tell them what dose to give, right? But a lot of our resources are really helpful on how to transfer a patient. In fact, I just handed one of our resources, and maybe we can put that in the chat, the resource on microdosing and cross tapering, because I had my project coordinator hand that to a hospitalist, so they knew how to do this. And it's a site example, but it was really helpful to get that information out there. So yeah, so again, your job, just push your resources, know the resources really well. And then what I did is I put my personal phone number on that resource, because as a clinician, I can help manage through. But again, the worst place for somebody to be is with untreated pain and untreated withdrawal. So like I said, either very aggressively treating pain or very aggressively treating withdrawal. And if you find that you want to advocate for a patient, it's just, again, a push of resources. Certainly not your job to figure out all the dosing on some of these very complex patients. So I just want you to get to know our resources really well. So in certain cases, if a physician's saying they're having trouble, you have the resources. The other thing I've asked my project coordinator, and we have a new substance use navigator starting, is if somebody who is an expert is not available in your hospital, you can also give the clinician consultation line, which is available 24/7. And we have that available, I think, on almost all the resources, but you can highlight it and say, hey, if you have clinical questions, this is a really good place to have those questions answered. And they are available to California clinicians 24/7. So I think that's a really good way to go. Again, you're there. So people ask you these questions, but I think it's really knowing the resources and being able to direct people to those resources. Does that make sense?
Yes, great question and answer session, Ariana. I love that. We will put the 24-hour clinician line, and that's a great, there it is, substance use warm line.
Thank you.
Because definitely getting a phone and handing it to the doc and telling them it's clinician to clinician. So that keeps our son out of, we're telling them what to do. So I really appreciate you going over that.
Yeah, and I just want to reemphasize again, it's, I know in my own facility, you get asked a lot of clinical questions and it can be very intimidating. And really, like I said, just know your resources and where to point people, know who are the experts. Hey, you should call this person, just because just so you know, and you don't have to feel uncomfortable. It's good to know some of the medications just because it's helpful for what you're doing, but this is not your job to figure out the dosing. So again, make sure, I think it's a really good place to send folks so that they get good information, because unfortunately, all of this dosing information can get really confusing. So again, just push those resources. And we have our algorithm, and it says 8 milligrams and bring them up to 24 milligrams. That's what we have posted in my emergency department. And that's what we've referenced. And we have lots and lots of resources just to help you. So is that helpful for everybody?
Yeah, they're saying a lot of us have used the warm line. Angela, if you want to say something about the warm line use, I would love to hear that from our Sun mentor, because you bring up just some great resources we already have, Ariana, and I really, really thank you. I know you're in the heat of the fire line, and to come and talk to us is huge. So I really, really thank you.
All right, thanks everybody.
I'm gonna leave you go, okay?
Okay,
I hope
thanks,
this was
everybody.
really helpful. If you have any more questions for Ariana, please feel free to let me know and we can send them back to her, definitely, okay?
Perfect.
Thanks,
All right.
Ariana.
Okay, thank you, everybody.
Thank you.
Okay, so next we're going to do our breakout sessions with our Sun mentors. We have a few questions that you guys can talk about, or you can continue talking about SBIRT and MAT if you want to. So we're going to leave that session up to you. Some other tips our Sun mentors can go over you are, what are the main things I should be doing as a Sun? Several people have asked, what should be my focus? The other thing is, do I need to know the buprenorphine protocols? That was great that Ariana just said, be familiar. It's not your role to know the dosages, but a great resource, she said, is print out the algorithms, laminate them, put them in a sheet protector and post them where the doctors are. It's a really good tool for you guys to use. So just want to know if there's anybody else. We're ready to go. I think all of our Sun mentors, are you guys all ready for our breakout sessions? I'm getting thumbs up from some of you. Okay. Before we get started, any other questions before? Again, we're going to put you in a breakout room, put on your unmute yourself and put on your video. And Caroline, are we ready?
Yes, I'm going to send you all to your breakout rooms now.
All right. That went by. It went by so fast, and it always does. So again, we're finishing up. Please fill out the evaluation to receive your CEU credit. I will also send the link versus an email. We just wanted to talk about the takeaways. Espert is a useful tool, so use it definitely. Buprenorphine can be used in many ways. We talked about fentanyl. We talked about a lot of things, but we have multiple protocols, and those are all on the California Bridge website. You were with our Sun Mentor team. I would like to think by now you guys know your Sun Mentors. You were in the rooms with them. They do a fantastic job. If you could just kind of raise your hand when I call your name. There's Christian. He is Bay Area, KP North and Providence North. Rebecca Bartley is from Riverside, Orange County, and Providence South regions. Latoya Mitchell is Dignity and Los Angeles. Say hi. Chaya Bang is Central Coast, South Bay, and Central Valley. Angela Caldwell, give a hi. Adventist in Northern Rural. Tommy Trevino is Sutter and UC. And Wendy Martinez is Desert Southern San Diego and KP South. Those are your mentors. And like I said, I hope you know them by now. Our next Sun Training 101 is Improving and Sustaining Your Program, Session 7, August 26th, coming up next Thursday. We have some really good guest speakers, including my boss, Serena Clayton. She will be talking to us about sustainability, just kind of sustaining your program, and also data. A lot of people have questions about data, so we will have John from our data team to talk to you guys. And so I kind of referred to him because I was given wrong information. So I said, let's get the expert here, okay, guys, because I'm not an expert on the data either. So again, he'll be here next Thursday. So we'll have some great speakers, as well as how to give a PowerPoint. We have a slide deck for a 15-minute Sun training if you guys want to see that, and I will share that with you. So that's next week. Also, we have our special virtual event. It's our National Overdose Awareness Day. Just join us. There's a link online. And we are just going to have a brief program. Dr. Alicia Kurtz is just going to give us some words of inspiration. We're going to have a 93-second moment of silence to honor and memory for those lives that lost in 2020, the highest year. And we're going to have some Sun speakers, as well as we're trying to get patients for some inspiration. So, it's a short half an hour. Bring your lunch. So we hope to see you there. You can join us on our social media. And of course, I am Sherry Cisneros, Director of the Sun Navigation Program here at California Bridge. We are always welcome to have questions, to call us, use Slack. Today is our Q&A session on Slack at 2:30. So we hope you join us. Anything else before we leave? Thank you, everybody. Thank you for all you do. And we so much enjoy having you on our trainings. This will be our last regional, but for next year for BHPP, we're already thinking, our wheels are spinning for the next trainings. Our Sun Training 101 has 3 more sessions. We're going to be on session 7 out of 10. Okay. All right, guys. Thank you and have a great day. We'll see you at 2:30 on Slack. Bye-bye.